Hello, everyone. I'm Dr. Paul Noble and my colleague, Dr. Tanzira Zaman. We're both coming to you from sunny Los Angeles. I hope you are all enjoying this CHEST meeting, which of course is still unfortunately virtual. We are at the Cedars Sinai Medical Center in Los Angeles. I'm the chair of the Department of Medicine, and Dr. Zaman runs our interstitial lung disease program. And what we are excited to do is take you through some really interesting cases and talk a little bit about our evolving thoughts on how we manage patients with fibrotic lung disease. The main theme being, how do we handle progressive fibrotic lung disease, almost independent of what the originating or underlying etiology is. So yes, this is these pictures. Dr. Zaman looks a lot better than I do, but we're thrilled to be here in Los Angeles at the Cedars Sinai Medical Center. This program is brought to you with the educational support of the Boehringer Ingelheim company. So we're the first up. We're hoping that you all stay tuned in to what are some really outstanding programs on various aspects of fibrosing lung disease. We're going to talk about progressive fibrosis, progressive fibrotic interstitial lung disease, and then scleroderma, IPF update, and COVID, all from outstanding places, Mount Sinai, University of Pennsylvania, and Yale. So I hope you all tune into these in between football games.
Should be great.
So just going to go through the pre-test questions so you have a sense of what we're going to go through and what you're going to answer towards the end. Pre-test number 1, what test or combination of tests provides the best indication of progressing interstitial lung disease? A, patient reporting increasing breathlessness. B, serial lung function alone. C, serial CT alone. Combining serial lung function with CT, or we're not sure. Pretest number 2, which of the following ILDs may progress? IPF, hypersensitivity pneumonitis, connective tissue related interstitial lung disease, all of the above, or I'm not sure. Pretest number 3, which of the following is an FDA approved medication for the treatment of progressive fibrosis ILD? Nintedanib, pirfenidone, mycophenolate, prednisone, or I'm not sure.
All right.
So we'll now transition to Dr. Zaman.
Sounds great. Okay, so I think the CHEST audience is very familiar with the fact that interstitial lung disease is an umbrella term that covers several hundred different specific diagnoses. And there are various classification systems that splits them depending on their mechanism of action or otherwise. Here I have them categorized into 5 different groups, not all encompassing. And when we are seeing patients for the very first time, splitting is really important. We want to get down to as specific a diagnosis as possible, because I think we can all recognize that we would treat a patient with, say, dermatomyositis-associated interstitial lung disease very differently upfront from someone with idiopathic pulmonary fibrosis. And not just for treatment, the specific diagnosis does give us really important information about prognosis and clinical course and perhaps systemic manifestations that are really important for us to be able to counsel our patients. However, what we do know is that even regardless of what the underlying diagnosis is and the importance of splitting, up to 20 or 30% of patients with any interstitial lung disease will acquire a progressive fibrotic phenotype. That is, regardless of directed therapies, the fibrosis process will become autonomous and it will progress constitutively as we are more familiar with in idiopathic pulmonary fibrosis. And so, Paul, would you go over the objectives for our talk today?
Absolutely. Number one, recognize progressive fibrotic interstitial lung disease. Number two, understand that non-IPF-ILD can also acquire a progressive fibrotic phenotype. Number three, review the general therapeutic options available for the management of progressive fibrotic ILDs.
Great. And now let's jump into our first case. So we have a 68-year-old man who is a former smoker with a history of gastroesophageal reflux disease who presented with progressive exertional dyspnea over the last year. He reports difficulty with climbing a flight of stairs, and he fatigues faster than he had been in prior years when he swims, but he's still able to swim approximately 3 times a week. We did an extensive survey of his occupational environmental exposures and were able to elicit none. And we did, as we do in most of our patients, obtain pretty extensive connective tissue disease serologies to evaluate for an occult interstitial or occult autoimmune process, even in patients who don't have a well-defined clinical presentation of an autoimmune disease. And this patient had none of those serologies that came back positive. And this is a review of his CT scan representative slices. And I think I'll go over the findings here. So you can see that the patient definitely has a peripheral predominant process. So in the upper lung zones, we're seeing some subpleural reticulation, maybe even some honeycomb cysts. And certainly the fibrotic changes are more extensive at the bases. So the bilateral bases appear to have more of the fibrotic changes and several rows of honeycombing at the bases. And you can see that more clearly here as well. So going further into the diagnosis for this patient, we discussed this patient at our multidisciplinary conference. We reviewed his radiographic pattern, which was a typical UIP pattern per the Fleischner Society classification for radiographic UIP, which also matches the ATS ERS Joint Society guideline description of UIP or usual interstitial pneumonia. And based on the lack of any history, exam, or serologic findings to support an alternate etiology, given he had an idiopathic UIP pattern, we diagnosed him clinically with idiopathic pulmonary fibrosis. As such, we started him on standard of care antifibrotic therapy. And this is the patient's physiology when we met him for the first time. So his forced vital capacity was a bit reduced and his diffusion capacity was quite reduced. And you can see the distance he was able to walk and that he did have some desaturation at the end of a 6-minute walk test. When we followed up with this patient 9 months later, he reported increased breathlessness and he'd stopped swimming. Looking at his serial pulmonary function test, we could establish that the patient was having a progressive phenotype. So looking at his forced vital capacity, that was declining over time, going from about 70% of predicted to 62% of predicted. And similarly, we were seeing a decline in his diffusion capacity. This was borne out by other physiologic testing that showed a shorter walk distance than what he was able to accomplish prior, as well as further desaturation at the end of a walk. So Paul, can you review for the audience methods we have to identify that patients are progressing, whether they have idiopathic pulmonary fibrosis or a different diagnosis?
Absolutely. And I always like to emphasize, first and foremost, the importance of really talking to your patient, because exertional breathlessness is really the cardinal manifestation. One of the challenges is that patients will generally become less active because they are uncomfortable. When they exert themselves, they tend to do less. So it's really important to try to get a sense of what their physical activity is. And in terms of more objective data, we like to generally get lung function, every 3 or 4 months. Not necessarily a DLCO every time, but we like to follow serial forced vital capacities, because we do know that the loss of forced vital capacity over time does correlate with poorer outcomes. It's interesting, when I first started training in Denver many years ago, we really thought the HRCT was going to be the be all and end all for assessing serially patients. And I don't think that's really turned out to be the case. It's absolutely essential, critical, probably the most important thing in terms of the initial diagnosis. But unless there's a change in symptoms to suggest perhaps an acute exacerbation, we don't typically get HRCTs more than once a year. It is important to keep in mind that if you do have a diagnosis of idiopathic pulmonary fibrosis, there is an increased incidence of lung cancer. So I typically, without a change in symptoms, will get an HRCT every year. But symptoms are really key in encouraging patients to maintain physical activity, walking, or other activities that they might particularly like to do. And I also really like to watch every 3 months the 6-minute walk. I'm not as keen on how far they're walking, although that is important. It's really what happens to that O2 saturation with walking. And that is really one of the prognostic factors that we take into account in determining whether somebody, for example, might be needing to get a lung transplant evaluation. So it's an amalgamation of these things: talking to your patient, lung function, a CT, and just keeping a close eye on their functional status. Thanks, Tanzira.
Yeah, thank you. All right, will you walk us through our second case?
Yes, our second case is a 77-year-old gentleman with a history of BPH who presents for the evaluation of fibrotic changes incidentally noted on CT. I only sort of half-jokingly make the comment, where Tanzira and I practice at the edge of Beverly Hills and West Hollywood, it seems like every time somebody sneezes, they get a high-resolution CAT scan. So we're seeing a lot more of these quote-unquote incidental findings. And this is a great example. Somebody, excellent functional status, playing tennis 3 times a week, doesn't really report any occupational and environmental exposures. It's so critical to elicit those. Here in California, we have a lot of bird lovers, but they don't often admit that they have birds, because they underlyingly know that it probably is causing their lung disease. And then an exhaustive look for a connective tissue disease, a little less critical probably in a 77-year-old man, but certainly any women need to be aggressively looked for connective tissue disease. And we'll make this point again during this, but I'd have to say, over the 2+ decades I've been taking care of ILD patients, I cannot emphasize enough how patients will initially present with what we think is IPF, and then 5-7 years later develop a connective tissue disease. I think that's one of the biggest challenges we face, because we will treat connective tissue diseases related fibrotic lung disease initially different than IPF. So it's something I spend a lot of time thinking about. But in this particular case, the connective tissue disease serologies, they're teasing us here. The CCP is at the exactly upper limit of normal, the SED rate a little bit high. The CCP is fascinating. I think we were really thinking it was going to be the be-all and end-all, but it's not entirely clear that you can't sometimes have a low-level positivity in IPF. Or is the patient going to manifest rheumatoid arthritis in the years to come? I think this is one of the most intriguing aspects about sorting these issues out.
Definitely.
So here's our chest CAT scan. It's incredibly unimpressive. There's a few little fine peripheral reticular opacities, but certainly nothing you'd get all excited about. And it goes very well with this gentleman's functional status. So in our multidisciplinary conversation, the radiologic pattern was indeterminate for UIP. Could it be something that's very early UIP? It possibly, but clearly no honeycombing for us to be able to establish that. So the clinical diagnosis was, this could be early RA-related ILD versus IPF, and it's not uncommon, even in men in their late 70s, for them to develop a rheumatoid arthritis-like picture. So the plan was to keep a close eye on him. He's playing tennis. We'll see how long he's able to do that. Follow him up every 3 months with lung function. If he develops any new symptoms. One of the things we always talk about also is getting rheumatology involvement. One of the things over my experience over the years, it doesn't seem like very often they can check off enough boxes to get rheumatologic diagnosis. But what I'm struggling with is, do I give them steroids or not? That's really what it's all about. Because if I'm convinced in my heart of hearts they have IPF, we don't really want to do that. We probably do more harm than good. So, but with a rheumatoid arthritis, in fact, we might actually get them better. So here's the lung function. We have 2 points in time, 6 months apart. We see the forced vital capacity 95% and 92%. Is that within the realm of error of our measurement? Entirely possible. DLCO clearly unchanged. So here we have pretty stable lung function. And, we will correlate that, of course, with his symptoms. Is he losing more regularly in tennis, for example? And is he attributing that to a breathlessness? That we would certainly ask about that. But at this point in time, based on what we have here objectively, it appears to be pretty stable. So interestingly, 6 months later, develops intermittent fevers, swelling of the small joints, and his repeat CCP is still 20, but his SED rate has bumped up. And our rheumatology colleagues have diagnosed him with palindromic rheumatism. So this clearly suggests that this underlying, form fruste, if you will, of a fibrotic lung disease is probably related to an underlying systemic disease process. And here we have another set of lung functions 6 months later. His forced vital capacity has trickled down, but a big drop in his DLCO. So we'll have some more imaging, I'm guessing, next, huh?
We will. Yeah, before we move on to that, I love this case, Paul, because you use that phrase, form fruste. And you were mentioning how sometimes our rheumatology colleagues aren't able to check off enough of those boxes to meet those really nice classification criteria for a specific autoimmune disease. But from our perspective as pulmonologists, what I say is we're not always looking for a well-defined autoimmune disease as we are in autoimmunity, identifying that risk factor that led to the development of the lung disease as a target for our treatment. And I thought this case demonstrated that really well. Not enough early on to diagnose someone with rheumatoid arthritis, and recognizing that the lung may be the first site of presentation for an autoimmune disease, even though that is not the site that gives us those points to be able to confidently diagnose someone with a specific autoimmune disease early on. Okay, so you mentioned that the forced vital capacity and DLCO were declining for this patient, and you're right, we've got some CT imaging. A little bit of a surprise here.
Wow, this is unusual for sure. You can clearly see at that left base there's pleural effusion, which of course does not occur in idiopathic pulmonary fibrosis. So it certainly supports this underlying autoimmune etiology for his lung disease. Interestingly, there's not been a big change in the fibrotic component. There's clearly some peripheral reticulation, but this is an example of a pleuritis, which is not incredibly common. But clearly, we would go down the route of treating with immunosuppressive therapy, and typically, as pulmonologists, our favorite drug is prednisone. But sometimes in rheumatoid arthritis, particularly with the joints, our rheumatology colleagues love methotrexate. We always get a little bit concerned about the possibility of methotrexate causing and interstitial lung disease, although perhaps that is somewhat overrated. But it is always a good conversation with our rheumatology colleagues as to what immunosuppressive therapy, to proceed with. So this gentleman actually underwent a surgical lung biopsy, which showed chronic fibrous pleuritis, lung with patchy chronic bronchiolitis with focal early bronchiolitis obliterans and peribronchiolar fibrosis. The vascular changes suggestive of pulmonary hypertension. So, rheumatoid arthritis related lung disease is fascinating because you can see so many different manifestations. You can see a flat out UIP pattern. You can see organizing pneumonia. And in this particular case, we see some bronchiolitis. Would have been interesting maybe to see some expiratory images there, because with bronchiolitis, you might see some air trapping. But clearly, this is somebody that we would be inclined to treat initially, most likely with prednisone.
That is
so he was, how much, Tanzira, what dose would you start with?
There's no magic, as you know, for this. I think in patients who are presenting with an autoimmune disease with a significant alveolitis component, I'm inclined to treat at 1 milligram per kilogram of ideal body weight. But for this gentleman who had really pleural effusion, not a whole lot in the way of acute ground glass infiltrates, I would go for a lower dosing, approximately 0.5 milligram per kilogram of ideal body weight. How about you?
I think that makes very good sense. And one of the things we always have to just remind ourselves, is to make sure that, they're getting calcium and vitamin D. And sometimes even some of our rheumatology colleagues will look to make sure look at their vaccination status, which isn't something I do as often probably as I should. Have they had all their vaccinations, because of the likelihood of, reactivating a variety of different viruses. But yeah, I think that's a great choice, particularly in older people, err on the side of maybe a little bit lower doses of prednisone. So it looks like we have follow-up lung function about 4 months later. And look at that DLCO, dramatic improvement, and as well the forced vital capacity. So this is, I know we'd like to say we see this all the time, but this is one of those that really puts a smile on your face that you've been able to significantly help your patient. And then, of course, the conversation will evolve to, can you treat with prednisone alone? Do you want to use a steroid-sparing agent? In this particular case, I'd be curious, Tanzira, what you decided to do, because it might be reasonable to go with prednisone alone because you've had such a dramatic increase. But what are your thoughts?
Yeah, this patient by this time was having quite a bit of the arthritic disease as well, and remained pretty well controlled and asymptomatic from a respiratory standpoint. And so really thinking about medications that could both treat the lung and the joints. With co-management with the rheumatologist, we landed on methotrexate. And actually this patient remains doing very well on methotrexate alone, both from a lung and a joint perspective. His pulmonary function tests, I actually just saw him in clinic last week, are stable off prednisone altogether. So he's just on methotrexate and has excellent control of both lung and joint disease. I see that we're getting a question from the audience about why a biopsy was done, because Paul, you had mentioned, we've got this like borderline CCP, we're seeing this pleural effusion that we really don't see in IPF. So between those two differential diagnoses, the second CT really leans us much more toward a diagnosis of rheumatoid arthritis. We didn't go into it to keep this case more straightforward, but the patient did have some other parenchymal changes that raised concern for a malignant process from the radiology standpoint. So that was part of the decision making as to why we pursued a surgical lung biopsy in this patient. I think I can envision a different situation in which this patient maybe has a CCP of 100 and has all the same findings, and we don't necessarily pursue that surgical lung biopsy. I think that borderline finding plus these other radiographic changes that we didn't mention, in which the radiologist evoked a concern for malignancy, pushed us toward pursuing the surgical lung biopsy in this case? Great question.
Yeah, that is a great question. And probably the thing that I like most about having had the surgical lung biopsy is the fact that you don't see UIP. So the long-term prognosis for this patient is dramatically better than if this had been an early UIP pattern, which you couldn't tell based on the CT alone.
Yeah, that's right. Okay. Well, I think we'll move on to the next case unless there are any other questions out there. Okay. So case 3, actually, let me just go back. There's another point I thought was important to make in this case. We talked a little bit about how we don't usually get a CT scan more frequently than annually unless patients have had a significant change in their symptoms or their pulmonary function test where we're concerned about an acute exacerbation or something of the like. And in this case, I think we really appreciate how the pulmonary function test alone didn't tell the full story. So if we had just looked at the PFTs and seen the decline in the forced vital capacity and the diffusing capacity and assumed that change, that decline, was due to progression in the fibrotic component of this disease, we really would have missed out on a couple of things. One, the true diagnosis, right? Because it was the presence of this pleural effusion, and ultimately the radiographic changes led us to pursue the biopsy that really cemented that certainty and that diagnosis. So if we had just assumed that what was causing the decline in the pulmonary function tests were progression of fibrosis rather than this new process like a pleural effusion, that really may have changed our management strategy in this case. So really goes toward why a combination of factors, in this case, the patient didn't have new respiratory symptoms, but the decline in the measures of physiology by pulmonary function testing with the new findings on the CT scan really changed the approach in this case. All right, moving on to the next. So our third case is a 58-year-old man. He had no significant medical history, and he presented to our ILD clinic for a second opinion. He'd been seeing other providers for a 5-year history of chronic cough that had been progressing in that time. And he also sought evaluation at this time because his dyspnea really progressed significantly and reported that he was now huffing and puffing when walking up a flight of stairs when he'd really been this very active individual with a really robust lifestyle. He had a very prominent occupational exposure. So he was a boat mechanic, and actually was practicing as a boat mechanic at the time of our evaluation. And he'd done this for many, many years, decades. And in that line of work had exposure to various fumes and solvents. We did, as we do with all of our patients, still assess for autoimmunity. He had an ANA, which was really not super impressive, with a titer of 1 to 40, and all of his reflex titers were negative, as were his CCP, rheumatoid factor, and an extended myositis panel. Here's his physiology. So he had multiple PFTs by the time we evaluated him. And over the interim, that year, he'd already shown really significant progression by his pulmonary function testing. So he had a decline in his forced vital capacity, whereas his DLCO had been relatively stable. And then here are some representative slices from the CT scan that he had available at the time of first presentation to our clinic. So very different from the other CT scans that we've seen, in that there is a pretty significant ground glass component. So ground glass opacities that are everywhere, but more patchy and bordering on like consolidative in some areas. I don't know how well this is projecting for you, but we do have traction bronchiectasis. So we've got these airways that are not tapering as they are heading out to the very periphery of the lung, that we take as a manifestation of fibrosis. So in these slices, you can see he's got these ground glass opacities, more traction bronchiectasis, and notably at the very basis, not as much involvement. So we're certainly not seeing honeycombing. We're seeing a little bit of reticulation down here, really not much in the way of traction bronchiectasis at the basis. So this is a ground glass predominant process that is preferentially affecting the upper lung zones rather than the lower. And so based on the presence of the ground glass opacities, his occupational history, we were concerned that this patient could have hypersensitivity or pneumoconiosis, really leaning toward a hypersensitivity pneumonitis. And so we pursued a bronchoscopy because often with transbronchial biopsies, we may see those characteristic poorly formed granulomas just with transbronchial biopsies that can really clue us into a diagnosis of hypersensitivity pneumonitis. And of course, BAL differential with the lymphocytic predominance also increases our suspicion for hypersensitivity pneumonitis as being the underlying process. So on transbronchial biopsies, we didn't get those characteristic poorly formed granulomas, but we did see other signs of airway-centered an airway-centered process, chronic bronchitis, as well as peribronchiolar metaplasia. So by the time of our multidisciplinary discussion, from a radiologic perspective, he had a pattern that was alternate to the diagnosis of UIP by our Fleischner and Joint Society classification criteria. And our radiologist opined that it was most suggestive of chronic hypersensitivity pneumonitis with those features of fibrosis as well as airway-centered disease as well as acute inflammation. And so we landed on a clinical diagnosis of chronic hypersensitivity pneumonitis. And since the group asked earlier about why we pursued a surgical lung biopsy in that patient, or perhaps why we did not pursue a surgical lung biopsy in this patient, since it would give us much bigger pieces of tissue and give us a much better chance at a pathologic diagnosis, the patient declined that. And so based on this clinical diagnosis of hypersensitivity pneumonitis, and given that this patient had what appeared to be a significant alveolar component, maybe an acute on chronic process, at our multidisciplinary discussion, the plan was to move forward with immunosuppressant therapy. So the patient was treated with prednisone and mycophenolate, eventually tapering down off prednisone and just on the steroid-sparing agent. Unfortunately, despite the initiation of this therapy, the patient had progressive loss of lung function. So looking at his pulmonary function testing, you can see his forced vital capacity declined sharply over the course of 4 months, even on therapy, as did his diffusing capacity. And this was matched by his symptoms of worsening breathlessness. And then the 6-minute walk test shows us not only that matches his PFTs and showing us that his physiology is progressing, but the 6-minute walk test, I think, can kind of objectify the patient experience. It can give us a quantification of really how this disease, as it is progressing or not progressing, is affecting this patient's quality of life and what he's able to accomplish day to day and the distance that he's able to walk in that time. Given the really low diffusing capacity, we did also, I wanted to make sure I shared with you the TTE results, because with that low DLCO and with someone who's got interstitial lung disease, hypoxemia, we worry about pulmonary hypertension. And I think the discussion about the limitations of a TTE as a test looking for pulmonary hypertension is for another talk. But for what it's worth, he had normal RV systolic function and a pretty low estimated PA pressure. And just to show you how his CT scan was evolving over that time, so perhaps due to the prednisone or just the nature of his disease, we're seeing less in the way of those really patchy, more bordering on consolidated ground glass opacities, but the fibrotic changes and mosaicism still persists. So the mosaicism really clues us into there being an airway component to this condition, or bronchiolitis on a pathologic level, but we're seeing lots of reticulation. We're seeing some patches of honeycombing. And again, we see that these changes really are more prominent in the upper lung zones than at the very lung bases. So given this patient's progression on immunosuppressant therapy, which we see as being first-line therapy for the clinical diagnosis of hypersensitivity pneumonitis, and the fact that he had progressive signs of progressive fibrosis based on his physiology, as well as the CT scan, we did initiate the patient on nintedanib given the results of the INBUILD study. So just to do a real quick summary of the INBUILD study. So looking at patients with progressive fibrotic interstitial lung diseases of any etiology other than idiopathic pulmonary fibrosis, because the effect of antifibrotic therapy in that condition had been well established. We're looking at the mean change in forced vital capacity in milliliters from baseline to 52 weeks. And what we see is that in the subjects who were treated with nintedanib versus placebo, there was definitely a better preservation of their forced vital capacity, a smaller change at 52 weeks from baseline in the decline in their forced vital capacity compared to placebo. And what I liked about the study is also there was a subgrouping of patients based on their radiographic pattern of UIP versus not. Because, Paul, let me know what you think about this, but we have known for a while that if patients have a UIP pattern, regardless of the underlying diagnosis, whether it's IPF or non-IPF, their outcomes do tend to be worse. And so one hypothesis may have been, well, in chronic progressive ILDs, the benefit of an antifibrotic like nintedanib may only be observed in the UIP group, but looking at patients who had a UIP pattern versus the overall population, it was pretty similar. Is that how you interpret this data?
Yeah, no, I completely agree. And it even harkens back to the original, IPF study in which only half the patients that led to approval for nintedanib had a UIP pattern. So it's true that while a UIP pattern portends a poor outcome, progressive fibrotic disease, even without that, clearly benefits from antifibrotic therapy.
Yes, and that even non-UIP pattern, other ILDs progress. Okay, so returning to our patient, so we did initiate him on nintedanib, and given his progressive fibrotic disease, we referred him to our lung transplant program. Here we have just his serial lung function. So nintedanib or no, he did over 3 months sort of attain some degree of stability in his forced vital capacity compared to prior, if you look at the trends after we initiate the nintedanib, and his diffusing capacity still continued to progress, albeit slowly. But this patient is pretty special to us because he was the first patient at Cedars Sinai to undergo a minimally invasive bilateral lung transplant. And Dr. Noble will talk to us a little bit more about that on the next slide, but it really is a remarkable story. There's a QR code here if you guys want to snap a photo of it, and it'll take you to a link of a video of a patient interview with Frank. So this is real patient, this is his real course, and he's been doing really great status post lung transplant.
Yeah, it's as Tanzira pointed out, and unfortunately, despite our best efforts, patients with chronic HP or connective tissue disease related can progress, and many of them will go on to need a lung transplant. But this is particularly exciting for us as IPF doctors and fibrotic lung disease doctors. We recruited this new team on the medical side, Dr. Ray Rampalo, who trained out at Stanford but ran the Ochsner Clinic, was the medical director at the Ochsner Clinic, and Dr. Pedro Catarino, who originally trained in the UK and then went to Duke for additional lung transplant training, and then was running a program in the UK where he learned this minimally invasive lung transplant procedure. And this is him in action. And I know many of you have probably taken care of patients who've had lung transplants, and you know that the challenges of the post-op care in no small part are due to the massive incisions that have to be made, particularly the clamshell for for a bilateral lung transplant. And so our team has been in place since January of 21. And actually, I just texted Ray, and they're doing their 46th transplant as we speak right now.
Wow.
So it's been and we've had outstanding results. And the patients do recover quicker, particularly in Los Angeles. It seems like we have a tremendous abundance of patients with fibrotic lung disease over the age of 70. And so this plays into their decision about whether to transplant somebody who may be, north of 70, 75 even perhaps. I know it's on an individual basis, but we wanted to share this with you because I don't know of too many other places in the country right now that are doing this minimally invasive approach. But it's exciting, and we're really thrilled with our team. I mean, our goal always, of course, we are, as Tanzira and I tell our patients, we fail when we don't prevent a lung transplant. Our goal is to prevent that. But despite our best efforts, we're not able to do that in a lot of cases. Hopefully, as new therapies, arise, we'll be able to get to the point maybe where we don't need to do as many lung transplants. But while the antifibrotic therapies have been a great step forward in terms of slowing the loss of lung function, they don't make people better. And so many patients, despite our best efforts with nintedanib, will still need to go on and have a lung transplant. So we thought we'd share that with you, particularly if any of your patients are inclined to want to explore this possibility. We wanted to make you aware of it.
That's right. And Paul, I think you made a really great point about, some of the limitations of antifibrotic therapy in that, they don't stop anything, they don't reverse anything. And in our patients for whom a lung transplant is an option, or even for those for whom it's not, an antifibrotic therapy can buy time on that transplant list, right? If we are able to slow the progression from the time we initiate the therapy, then it does allow for more time on the transplant list, since that is unpredictable. This patient was very lucky to have been transplanted at a short interval after he was listed, but that's not the case for everyone. And so for those patients who are listed for transplant, the antifibrotic therapy can buy them more time until they do find a match and are transplanted. Okay.
Yeah, I think that's correct. And the only other brief point I would make is that if you have somebody that you don't think is IPF and you are treating their underlying etiology with immunosuppressive therapy, at that first sign of decline, sometimes patients will feel a little bit better, and maybe you won't see them for 6 months. It's really a good idea to see them every 3 or 4 months. And if there's a decline in their walk distance, their O2 sat, or their forced vital capacity, to add in, nintedanib. I think that triple therapy approach, where you're treating the underlying etiology, if it's autoimmune related or chronic HP, plus an antifibrotic, I think that's the wave of the future. And even in the scleroderma study, those patients that were on mycophenolate and nintedanib did better than those patients that were on nintedanib alone. So keep that in mind as you treat your patients with this progressive fibrotic phenotype.
I couldn't agree more with your point about not taking your eye off the ball when it comes to patients, because with IPF certainly, but with our other fibrotic lung diseases, the course can be unpredictable. So patients who are stable or very slowly progressing for a period of time can move onto a curve of more sharp decline, at which point we really want to expedite that referral to lung transplant. They're already on triple therapy, as you like to call it, Paul, with immunosuppression as well as antifibrotic medications. All right. So Paul, you also queued it up really nicely, mentioning the systemic sclerosis ILD, because that is the next in this series of talks. But we do have time in this session to take questions. We've received some great ones from the audience so far. So please feel free to chime in, raise a hand, or type something into the chat box. We'd love to take your questions, or hear your thoughts about these cases or this topic. Okay, I'm seeing a question from Caitlin. What is your success of getting antifibrotics for progressive fibrotic ILD patients approved by insurance? Paul, do you want to take that?
Sure. We are fortunate. Tanzira runs our clinic, and we have a great group of people that we work with. So our success, and she sees more patients than I do, so she can comment as well. But generally good success. The one challenge we face is sometimes patients have a significant copay. And that is a challenge. I know that the BI folks work with them on that, but it is sometimes that copay can be pretty high. But we have a really high success rate of getting nintedanib and pirfenidone both approved. Tanzira, what's been your experience?
Yeah, I will say I think this is a credit to our clinic staff. We have a lot of ancillary support, and this may be a plug for referring patients to ILD centers to co-manage. If you're a pulmonologist not at one of these centers, is just we have a lot of resources to help us to get these drugs into the hands of patients who need them. And so I actually can't think of a time when I was unable to get a patient with progressive fibrotic ILD their antifibrotic medication. Sometimes does it take an extra step or two to make that happen, for sure, but we're generally able to do that pretty successfully. I think we had another question.
There was another question, yeah. It was about when to start the nintedanib, and I think in that chronic HP patient,
Yeah.
could you have started it right up front? I would say yes, but the one caveat is because the patient had not been treated with immunosuppressive therapy, we can sometimes see those people get better. And that's the one worry I have when someone goes right to an antifibrotic, because the antifibrotic is not going to make them better. And granted, many chronic HP patients, if they've had it for years, the likelihood of them improving is, of course, much less. But still, we have all been surprised from time to time. And also, when you're one of the other challenges, of course, is there are tolerability issues with these medications. So we tend to try to not start all three of them at the same time, just because if we kind of get into trouble with tolerability issues, you don't know which medication it is. So I would still tend to try to initially go with prednisone and add in mycophenolate, but a very short follow-up if they're not improving, then I think it's very, very reasonable to add in nintedanib. What do you think, Tanzira?
Yeah, I agree with you 100%. I think looking at that case, in retrospect, we see that he progressed despite immunosuppressant therapy, but I think we have plenty of cases in which patients achieve not only stability, but improvement with immunosuppression. So in that case, my reason for not starting everyone on an antifibrotic if they've had some evidence of progression up front is I don't know if the risks are going to be worth the benefit. So once I've seen that someone has progressed on what we believe to be the first line standard of care therapy, that's when, from my perspective, the risks of that therapy are justified by the benefits. We've got a number of questions. Let me try to work on them backward. What is your threshold improvement to determine steroid responsiveness? Okay, Paul.
Sure. Yeah. It's a great question. Certainly, we can't rely exclusively on subjectivity, but it certainly is never a bad sign when a patient of yours tells you that they're feeling better. But of course, we know it could be the euphoria of the prednisone. I really like cough. If that cough gets better, that's really a good sign that whatever is driving the fibrotic disease may have a steroid responsive component. But of course, the gold standard is objective data. lung function, walk test, and depending on what the CT pattern is, that might be, if it's not a UIP pattern, then we would typically, that's where we would get a CT scan, probably 3 to 6 months into the initiation of therapy to see if we do see improvement. Because if we see improvement, we know they don't have IPF. And then we can hopefully manage them with I like to say judicious immunosuppressive therapy. I tend to use a little bit less than the rheumatologists use in terms of the mycophenolate dose, just based on my empirical experience over the years. But we're happy with any objective evidence, but you have to be careful, particularly in older patients, as you know very well. The side effects of steroids are not trivial, particularly on bones, varicella activation, things along those lines.
Yeah, we have some other steroid-related questions. So I'll give you my take on the steroid responsiveness. So typically, I'm using steroids for patients who have, evidence of an acute component of their disease. So radiographically seeing ground glass stuff on top of fibrotic changes. Usually I'm not seeing pure fibrotic changes in those patients. And when I'm trying to do this steroid trial for responsiveness, I'm actually very regimented about getting pre and post data. So I'll get that pulmonary function test right as they're going on therapy, and then get one like 6 to 8 weeks later after they're on steroids, and or a CT scan, depending on the extent of what was seen radiographically initially. And then we have another question about steroids. Are you saying that for chronic HP, the therapy should be prednisone and mycophenolate and considering adding OFEV, or are you saying for ILD should consider a trial of prednisone and mycophenolate? We're talking about HP. So we don't think that for any interstitial lung disease that you see for the first time that you should do a trial of steroids. I think, Paul, we are very aligned on that, not just throwing everyone on steroids. That's a very individual decision that is made not only by what our multidisciplinary diagnosis is, but also on that individual patient and their trajectory and their findings, and the pretest probability that they're likely to be steroid responders or immunosuppressant responders. Not everyone who has a condition that we believe will be responsive to immunosuppression necessarily gets high or medium dose steroids, right? So for patients with certain autoimmune interstitial lung disease, if they're not having an acute presentation, or their radiographs don't show a significant acute component, we may just start them on mycophenolate or rituximab, depending on what we're seeing. So very customized, individualized therapy, rather than treat everyone with steroids, and if they fail steroids, then treat them with antifibrotic. That's certainly not our approach. And then what else? We had some other questions. What are your thoughts on referral to pulmonary rehab for these patients? I'm not aware of robust data for this in IPF or PF-ILD, but we have noticed significant quality of life improvements in patients who undergo pulmonary rehab. So Charles, I'm going to make a plug for one of my residents, because we looked at this, because the anecdotal experience that you're reporting, we were observing in our clinic as well, that our ILD patients, we track not only their 6-minute walk distance, but also their depression scores and their shortness of breath scores pre and post pulmonary rehab. And I was seeing these dramatic improvements. So plug for everyone here, check out an abstract by Jason Wong, a Cedars Sinai resident, who looked at changes in depression score and the UCSD shortness of breath questionnaire score in patients with interstitial lung disease. And we also compared all of our ILD patients, so combination of IPF and non-IPF ILDs, to the outcomes observed in COPD. And we also looked at whether the severity of these quality of life issues at baseline had an impact on patients benefiting from pulmonary rehab, and spoiler alert, it didn't. So patients who had the highest depression scores versus the lowest, all patients seem to have an improvement in their quality of life measures. So check out that abstract, and great question. I think Paul and I are big proponents and endorsers of pulmonary rehab for improving quality of life.
Absolutely.
Other questions. What are your thoughts on starting antifibrotics in sarcoid patients already on methotrexate or Cellcept? Paul, any thoughts on
So
that?
you're the sarcoid person, Tanzira. I will defer to you.
Yeah. So my general approach to this is the same as it is for, our other ILD. Sarcoidosis, although a systemic disease, autoimmune diseases or connective tissue diseases are also autoimmune diseases. My approach is the same as it is for, say, an autoimmune condition. So I treat it up front with directed immunosuppression, whether that's methotrexate or Cellcept. I choose probably more often. And if patients are clearly having progressive fibrotic lung disease despite directed immunosuppression for the instigating disease, I will initiate antifibrotics.
Yeah, there were a handful of sarcoid patients, I believe, in the InBuild study.
Good question. For following ILD/IPF, is there a particular reason why FVC is followed over TLC from an SVC or slow vital capacity? So I think this is a practical. I remember asking this question when I was a fellow working with the great Joyce Lee at Colorado. And part of it, spirometry in research settings, spirometry is easier, cheaper, and more easily reproduced. And when we look at all of our studies of clinical predictors of progression in IPF in particular, the forced vital capacity is one of the best predictors of outcome, the change in the forced vital capacity. So that's why we follow the forced vital capacity at our center. Anything to add on that topic, Paul?
No, it's just exactly right. It turned out to be the most reproducible measurement from the standpoint of clinical trials.
Recent chest physician paper recommends classifying HP as fibrotic and non-fibrotic. What is your take on that, since most patients tend to have an overlap? So I think if you have a purely non-fibrotic, so acute hypersensitivity pneumonitis, yes. But if you have any fibrosis, that's chronic HP or fibrotic HP, which may also have an acute component on top of it. So generally, we do agree with that and follow that classification of non-fibrotic versus fibrotic. For patients with non-fibrotic HP or acute HP, you may call it, I think there's a greater opportunity that those patients may not need a long-term immunosuppression, especially if you can identify that exposure. And so if the physiologically the presentation of HP is mild and there's a very clear trigger for it, some providers may not even necessarily treat that with immunosuppression upfront. I think certainly if a patient's having significant symptoms or physiologic abnormalities with an acute exacerbation or an acute presentation of HP, we want to treat that and reverse that and really do our due diligence to find that antigen. We didn't emphasize that as much in that third case, but we do know from prior studies that in patients with HP, for whom we can identify a specific trigger and remove them for that trigger, those patients tend to have a better outcome than patients for whom we are unable to identify or remove the trigger for their disease. Okay, we have another question. Is there data on steroid-sparing immunosuppressants for HP? Not prospective or randomized data. There are a number of retrospective papers on looking at immunosuppression for HP, but the limitation there is that if you're looking at a control group of HP patients who didn't get treated with immunosuppression, ask why did those patients not get treated? Is it because they, baseline already had achieved disease stability, perhaps because they've removed the antigen, or they just weren't asymptomatic? So that's really tricky about looking at steroid-sparing agents from a retrospective perspective in HP. So comparing patients who got steroid-sparing agents versus who didn't. I do believe out of the University of Chicago group, there was a comparison retrospectively of patients who were treated with mycophenolate versus azathioprine and similarities in outcomes among those patients. So go ahead and look that up. I think Mary Struck is on that paper. Any other questions? I think
we're are we out of time, sadly? We're having so much fun.
But I do think we got to, I think, all of the questions. Really great, intelligent questions from the group that really get to the complexity of managing interstitial lung disease. And again, to make a plug for those of you who are not necessarily at an ILD center, the multidisciplinary setting and discussion is so helpful in working out some of the more complex components of managing these conditions. And we routinely do and are very happy to co-manage with pulmonologists who are not at ILD centers. Thank you guys so much for your participation.
Yeah. Enjoy your Sunday.